Hello students. Welcome to our chapter concepts of care for patients with conditions of the central nervous system. This is your chapter 40 in the 10th edition of the book, and this is chapter 37 on the 11th edition. So we're going to start this chapter talking about multiple sclerosis. So multiple sclerosis is a chronic disease caused by immune, genetic, and or infections factors that affects the myelin sheath and nerve fibers of the brain and spinal cord. It is one of the leading causes of neurologic disability in young and middle-aged adults. It's a chronic disease. It has immune causes, genetic, and or infection factors. Okay, pathophysiology characterized by periods of remission and exacerbation flares. As the severity and duration of the disease progresses, the periods of exacerbations become more frequent. Patients with MS can have a normal life expectancy as long as the effects of the disease are managed effectively. So what is multiple sclerosis? I always love to start with a video. Before that, a good way to remember this is that multiple sclerosis, the first letter of multiple is M, corresponding to myelin. Sclerosis is S, sheath. So it's a problem with the myelin sheath, multiple sclerosis. That's a good trick, right? To remember it. Okay, students, so let's watch this video. You're gonna love it because I am selecting videos that are straight to the point and very short. Okay, let's see.
Multiple sclerosis is an immune-mediated disease in which the body's immune system attacks the nerves in the brain and spinal cord. This disrupts the flow of nerve signals throughout the body. Nerve fibers have a protective sheath called myelin, which insulates the nerves, aiding the fast transmission of electrical signals along the nerve fibers. In multiple sclerosis, an unknown trigger causes the immune cells to start attacking and breaking down the myelin sheath. Over time, repeated damage causes hard scar tissue, known as plaques, to form on the nerve. As a result, the nerve impulses are disrupted because the electrical signals can't travel as fast and may leak out between the damaged myelin. Vision, speech, movement, and sensation can all become affected as these functions require effective communication between nerves.
Thank you so much for this video. So right there, many conditions in the central nervous system, okay, can cause problems with sensation and motor, okay, abilities. But the vision is a symptom that we have to consider when we try to differentiate between multiple sclerosis and a amyotrophic lateral sclerosis, AML, okay, or ALS. So we have to consider the vision factor here. Let's go deep into this. So multiple sclerosis, we are calling this disease right now, from now on, MS, is characterized by demyelination, loss of myelin sheaths, diffuse random or patchy areas of plaque in the white matter of the central nervous systems are the definite findings. So the plaques are the remaining, the residual parts of the cells that are being destroyed from the myelin sheaths. So the areas particularly affected include optic nerves, spinal pyramidal tracts, spinal posterior columns, brain stem nuclei, and the ventricular regions of the brain. The four major types of MS are clinically isolated syndrome, CIS, relapsing remitting, primary progressive, and secondary progressive. So the clinical isolated syndrome lasts for at least 24 hours. Clinical isolated maximum 24 hours. An MRI may or may not show evidence of MS, so a diagnosis is not yet possible. That's the problem con multiple sclerosis. Initially, is the evidence in the imaging is not clear, so the neurologists, the providers cannot identify the disease until this one progresses. Okay, so the clinically isolated in the imaging may not show evidence. A little over half of patients diagnosed with clinical isolated syndrome develops MS within 10 years. You see, so it's a long time until they develop and is diagnosed. And disease-modifying therapies are often started to prevent or delay the onset. So radiologically isolated syndrome, RIS, is often diagnosed incidentally in a person having an MRI for another problem, such as headache or head trauma. So it's incidental diagnosis. It is characterized by isolated lesions that are similar to those of MS in a person who does not have a past or current history of symptoms of the disease. Let's continue. Relapsing remitting multiple sclerosis occurs in most cases of MS. Looks like this is the most common. The course of the disease may be mild or moderate. Symptoms develop and resolve in a few weeks to months, and the patient returns to baseline. During the relapsing phase, the patient reports loss of function and the continuing development of new symptoms. So that's important to analyze during the relapsing phase how the disease is going to behave. Primary progressive multiple sclerosis, PPMS, involves a steady and gradual neurologic deterioration without remission of symptoms. So it's going to be gradual and steady. The patient has progressive disability with no acute attacks. Patients with this type of MS tend to be between 40 and 60 of age at onset of the disease. Secondary progressive multiple sclerosis begins with a relapsing remitting course that later becomes steadily progressive. Many people with this type, secondary progressive multiple sclerosis, are having first the relapsing remitting multiple sclerosis. So they start with the relapsing remitting, and then this one converts into secondary progressive multiple sclerosis within 10 years. The current addition of disease-modifying drugs as part of disease management may decrease the development of secondary progressive multiple sclerosis. There is another one, progressive relapsing multiple sclerosis is an older label for an uncommon type of MS characterized by frequent relapses with partial recovery but no return to baseline. Don't get confused and just relax. I know there are too many definitions and types between the seizures and the multiple sclerosis. Your work as a nurse is to know this knowledge, and then your main focus is to practice the nursing care. Okay, so we're gonna get deep into that. Relax. Okay, don't panic. Etiology and genetic risk involves multiple immune, genetic, and/or infection factors, although changes in immunity are the most likely etiology. The disease is seen more often in the colder climates of the northeastern Great Lakes and Pacific Northwestern states and in Canada. Well, we have to consider, if we are talking about the colder climates, we have to consider also the countries that are in the Nordic part of the world, Norway, Sweden, right? Russia. So probably we don't have the statistics that correspond to that part of the world, but we are considering the ones that are closer to the US. Familial patterns of multiple sclerosis. Having a first degree relative, such a parent or sibling with MS, increases a person's risk for developing the disease. Research also confirms the association of MS with over 100 gene variants, including interleukin 7 and interleukin 2 receptor genes. Professor Matalana, what is interleukin, please? Could you please clarify? So interleukin is any of a class of glycoproteins produced by leukocytes for regulating immune responses. What are leukocytes? These are the second most common type of white blood cells. Remember, our nerds love to monitor. Neutrophils, first place, leukocytes, the second, and monocytes, the third. So the leukocytes, okay, are going to produce glycoproteins. What is glycoproteins, Professor Matalana? So are proteins that are having a component of carbohydrates. That's why they are called glycoproteins, okay? And these proteins are produced by the leukocytes for regulating immune responses, okay? Incidence and prevalence. MS usually occurs in people between the ages of 20 and 50 years. Let me close the window. It looks like there is something going on with the police and the firefighters. Okay, let me close the window. Okay, so you see. Okay, happens in the best families. Okay, MS usually occurs in people between the ages of 20 and 50, but cases may occur at any age. Nearly 1 million people in the US have MS. 1 million. The disease affects over 2.3 million people worldwide. 2.3. And in Canada, there is 90,000 already reported in the statistics. So there are a lot of countries. You see 1 million plus 90,000 is not 2.3 million together. So I'm assuming other cold countries, especially the Nordics, right? Norway, Sweden, they should be in the list. And remember, these statistics are coming from the National Multiple Sclerosis Society, which is from the US. I don't see any statistics from any worldwide organization. But we have to consider, right, other facts. Now, women and multiple sclerosis. MS affects women 2 to 3 times more often than men, suggesting a possible hormonal role in disease development. Now, our assessment, history. Multiple sclerosis, MS, often present like other neurologic diseases such as amyotrophic lateral sclerosis, sclerosis, which can make the diagnosis difficult and prolonged. ALS is also a progressive neurodegenerative disease that affects neurons in the brain and spinal cord. In that sense, both are the same, right? Affects neurons in the brain and spinal cord, and that is likely caused by genetic mutations. So they are not talking here about immune. Multiple sclerosis is genetic, immune, and they have other factors. Unlike MS, there is no establishment, treatment, or cure for ALS, which is 100% fatal. Yes, and I know a couple of patients that I've seen with ALS. Recently, a combination drug, sodium phenylbutyrate and taurursodol, have been approved to slow physical function decline for patients who have ALS. So let's go to the race and multiple sclerosis fact. MS has historically been thought to occur most often in white individuals. However, a recent study shows that MS is nearly as prevalent in the Black population as in the white population. So let's watch, let's see this table. It's a comparison between multiple sclerosis and ALS, amyotrophic lateral sclerosis. So the pathophysiology, you see the immune-mediated demyelation and nerve injury characterized by remission and exacerbations. So in ALS, you have a chronic neurologic disease, genetic and environmental factors causing progressive muscle weakness and wasting and leading to paralysis of respiratory muscles. It's a very sad disease, ALS. So the immune component is not there. And basically, they are talking about the multiple sclerosis. They have a participation of the T cells as well, causing this immune response, right? So population affected, we have women twice as often as men. In ALS is more men than women between the ages of 40 and 60s. Signs and symptoms, both are having fatigue. MS is having muscle spasticity. Double check on the vision, blurred or double vision. This is the differential. Nystagmus, scotomas is deficiencies in the peripheral vision. But basically that's the main difference. Here you have the muscle atrophy, weakness, dysarthria. What is dysarthria, Professor Matalana? Weakness in the muscles used to speech, which often causes a slow or slurred speech. What is dysphagia? Is difficulty swallowing. At this point in your program of nursing, you should be very familiarized with this. I'm just reviewing because memory is fragile. Now, interprofessional collaborative care, you see that MS, because there is an immune component, they are going to use antineoplastic drugs. They are also going to use monoclonal interferon medication. We are going to see that later. Versus ALS, they are going to provide support to promote optimal function. Palliative care is going to be the main intervention for these patients, and psychosocial support. Now, physical assessment, signs and symptoms. You know your old cards in the morning. You need to conduct your assessment. Some patients with RRMS also report pain. Let's go to remember RRMS is relapsing remitted multiple sclerosis, which is one of the most often types of MS. Psychosocial assessment, how long it takes to establish a diagnosis of MS. That's the issue, because as we were talking at the beginning, in the imaging, sometimes there's no evidence at the beginning of the presentation of the disease. So the plaques probably are not going to be seen. Probably there's not going to be evidence of destruction of myelin sheaths. So it takes time to finally make the diagnosis. Some doctors are going to confuse the symptoms, and they are going to say that those are related to stress and anxiety. Maybe the weakness and fatigue is going to be related to, the doctor is going to try to make a relation with other conditions. Like, for example, it comes to my mind right now, fibromyalgia, changes in vision, and are diagnosed with exhaustion and advised to get more sleep. So yes, I know many patients that are having problem with vision, and they develop, for example, some dryness in the eyes. So all these diseases are being treated separately, but not they don't put together to consider MS as a diagnosis until the disease is progressing. Depression may occur at the time of diagnosis and can also occur later with disease progression. Assess debilitating disease. Secondary depression is the most frequent mental health disorder diagnosed in patients with MS. So you need to double check the stress management skills in preparing for a chronic, potentially debilitating disease. This is very important. Stress management covers from the support from the family, friends, even the religion, the culture. So it's very important when you know your patient, what religion, what culture is he coming from, what are his habits, who is around him, if he's practicing any type of meditation, yoga, sports. Sports really helps to relieve depression, anxiety, and helps with the mental state. So all these factors you need to assess. Changes in cognitions are usually seen late in the course of the disease and can include decreases in short-term memory concentration and the ability to perform calculations, inattentiveness, and impaired judgment. Assess the impact of bowel and bladder problems. Managing urinary or fecal incontinence or constipation can be time-consuming and embarrassing. But remember, all these patients that are having this motor impaired motor functions, and you want to help them with the constipation, remember, especially MS, they are having dysphagia, probably they are not going to be able to eat proper nutrition. They need support in that sense. Remember your high intake in fiber, fluids, and if they cannot perform regular exercises, the physical therapy can come home and can, provide exercises, even if they are in the bed or in the sofa. All those three are going to promote regular bowel movement if constipation is the issue. Key features: multiple sclerosis, common symptoms and conditions, numbness or tingling sensations, the paresthesias. Please always make an assessment, a thorough assessment of the vision. So that could be your differential, and you can help in the diagnosis of the disease to make a sooner diagnosis. Bowel or bladder dysfunction, depression, dysesthesia. I'm going to play a video of this because is going to help you not only for this disease, but for other conditions that we are going to see across your career. Okay, let's play this video.
Today's medical-centric topic is everything you need to know about dysesthesia. What is dysesthesia? Dysesthesia is a neurological condition that causes an abnormal, uncomfortable sensation on the skin. This sensation can feel like burning, tingling, itching, or numbness, and it can occur anywhere on the body. Dysesthesia can be chronic or intermittent and can be triggered by various factors such as temperature changes, pressure, or touch. Symptoms: dysesthesia. The primary symptom of dysesthesia is an unpleasant or uncomfortable sensation on the skin. This sensation can vary in intensity and duration, and it may be accompanied by other symptoms such as burning, tingling, or itching sensations, numbness or reduced sensation, increased sensitivity to touch or pressure, muscle weakness or stiffness, difficulty sleeping or concentrating, anxiety or depression. Causes: dysesthesia. The exact cause of dysesthesia is not well understood, but it is thought to be related to nerve damage or dysfunction. Some possible causes of dysesthesia include diabetes, multiple sclerosis, spinal cord injury, peripheral neuropathy, Lyme disease, herpes zoster, shingles, certain medications, vitamin deficiencies. Diagnosis and treatment: dysesthesia. Diagnosing dysesthesia can be challenging as there are no specific tests to confirm the condition. Your doctor will likely perform a physical exam, review your medical history, and order blood tests and imaging studies to rule out other possible causes of your symptoms. Treatment for dysesthesia typically involves addressing the underlying cause of the condition if known. For example, if diabetes is the cause of your dysesthesia, managing your blood sugar levels may help alleviate your symptoms. Other treatment options may include antidepressant or anticonvulsant medications to help control nerve pain, topical creams or ointments to soothe the skin, physical therapy or occupational therapy to improve muscle function and reduce pain, relaxation techniques such as deep breathing or meditation to help manage stress and anxiety. In some cases, surgery may be necessary to relieve pressure on nerves or correct a structural problem that is causing your dysesthesia. Dysesthesia is a neurological condition that causes uncomfortable or unpleasant sensations on the skin. While the exact cause of dysesthesia is not well understood, there are several treatment options available to help manage the symptoms. If you're experiencing persistent or bothersome sensations on your skin, it's important to speak with a healthcare provider to determine the underlying cause and develop an appropriate treatment plan.
Thank you so much.
Thank you for watching our video. Please
Okay,
do not...
thank you. This was a great video. Think about your diabetic patients. Think about that some of these patients with dysesthesia are going to be referred to the allergic provider, right, to conduct an allergic test. What about if this dysesthesia is confused with scabies? That's why assessment and observation is crucial. That's why I decided to play this video, right? Probably some people is going to think, let's check the bed for bed bugs, scabies, allergies, who knows? And probably probably in this case, in multiple sclerosis, the issues coming from the nerves. So for these patients, sometimes they are even going to the dermatologist. The dermatologist is going to prescribe mild steroids, or in my case, usually when the patient is presenting with this type of itchiness and I don't know where this is coming from, I suggest Eucerin. The one that is, the ingredients is the oatmeal. It's very natural and is working very well. So let's continue. Less common symptoms and conditions. Also you're having ataxia, which describes poor muscle control that causes clumsy voluntary movements, and it may cause difficulty with walking and balance, hand coordination, speech and swallowing, and eye movements. So you have less common symptoms and conditions here. Tinnitus, for example. Sexuality can be affected in people with MS. Laboratory assessment. No single specific laboratory test is definitely diagnostic for MS. However, the collective results of a variety of tests are usually conclusive, and the collection of all the symptoms and the presentation, right? Abnormal cerebrospinal fluid findings include elevated proteins, oligoclonal bands, and an increase in the white blood cells count. Cerebrospinal fluid electrophoresis reveals an increase in the myelin basic protein and the presence of increased immunoglobulins, especially immunoglobulin G. Other diagnostic assessment, an MRI of the brain and spinal cord that demonstrate the presence of plaques in at least 2 areas is considered diagnostic for MS. So plaques in 2 areas. Evoke potential testing. Usually the visual evoke response may be performed for patients suspected of having MS. This non-invasive test can identify impaired transmission along the optic nerve pathway. Discusses this test in more detail in chapter 35, which we spoke about already. So you have this NCLEX examination question. The nurse is caring for a client recently diagnosed with MS. Which of the following common client findings would the nurse expect? Select all that apply. Muscle weakness? Yes. Memory loss? Yes. Visual changes such as diplopia? Yes. Hallucination? No. Vasospasticity and fatigue. Yes, you can check the table 37.1. I think it's the one. Yes, box 37.1, and confirm these answers. So the most important factors for nursing care are impaired immunity, decreased or impaired mobility, decreased visual acuity, and cognition. So how are we going to manage immunity? The patient with MS is expected to be free from episodes of secondary infection due to impaired immunity from the disease or from drug therapy used to manage the disease. Dr. Matalana, why the drug is causing impaired immunity? Because we are going to see the types of drugs that are going to affect the immune system and the bone marrow. It's coming. Interventions, as with any chronic disease, clients who have been diagnosed with MS are at increased risk for infection. Teach this patient to avoid large crowds and anyone who is sick. Remind them to wash their hands frequently and use hand sanitizer when soap and water are not really available. And this is good to know. It's coming. And also it's going to be on your NCLEX exam. So if they are getting medications that are going to be modulating the immune system, probably it's obvious they are going to be on increased risk for infection. Therefore, they need to avoid large crowds and everyone who is sick around them. Drug therapy medications can be administered orally, by injection, or by infusion, and they include immunomodulators or anti-inflammatory medications that can alter immunity and place patients at risk for secondary infection. Other medications are used to control symptoms such as bladder or bowel dysfunction, because we need to take care of these issues as well. Fatigue, itching pain, sexual problems, spasticity, tremors, or gait disturbances. So here you can see the typical plaques that the arrows are showing, seen in the brain CT images of patients with multiple sclerosis. Examples of drugs used for treatment of MS: interferon beta preparation. Professor Matalana, what is interferon? Interferon are proteins that are part of your natural defenses. They tell your immune system that germs or cancer cells are in your body, right? And they trigger killer immune cells to fight those invaders. Interferons got their name because they interfere with viruses and keep them from multiplying. What are your killer immune cells? Your T cells and your B cells, right? And your T cells and your B cells. So interferon is the soldier that is, watching around, and it's going to tell the immune system to create these killer cells. So we have interferon beta preparation. We have immunomodulators that modify the course of the disease and also have antiviral effects. We have mitoxantrone, an IV antineoplastic, anti-inflammatory agent used to solve relapses but with risk for leukemia and cardiotoxicity. And this is NCLEX alert. All medications that are basically attacking the most important organs and the bone marrow is going to come in the NCLEX. So mitoxantrone is an antineoplastic that can cause leukemia and cardiotoxicity. Okay. Natalizumab, the first monoclonal antibody approved for MS that binds to white blood cells to prevent further damage to the myelin sheath. Dr. Matalana, what is a monoclonal antibody? So the monoclonal antibody is an antibody produced from a cell lineage made by cloning a unique white blood cells. Monoclonal is cloning a white blood cells, are man-made proteins that act like human antibodies in the immune system. Okay, so safety alert. The interferons we know are the soldiers that are checking the surrounding, are subcutaneous injections that patients can self-administer. Teach patient how to give and rotate the site of injections. The same we do with the insulin, right? We rotate the site of injections because local injection site can cause skin reactions, and the first dose of these drugs are given under medical supervision to monitor for allergic response, including anaphylactic shock. So these medications are no joke. Teach patients receiving them to avoid crowds and people with infection because these drugs can cause bone marrow suppression. There you go. Remind them to report any sign or symptoms associated with infection immediately. Instruct patients about flu-like reactions that are very common for patients receiving any of the interferons. The symptoms can be minimized by starting a low drug dose and giving acetaminophen or ibuprofen. Adverse effects of glatiramer are not common, which is a type of interferon medication. So yes, we are taking a lot of information here, but everything is in order for the benefit of the patient and to protect your license. Nurses, take notes of the NCLEX material. Natalizumab, a humanized monoclonal antibody, can cause allergic or anaphylactic reaction when each dose is given because the drug tends to build up in the body. Patients receiving this drug are at risk for progressive multifocal leukoencephalopathy, PML. The opportunistic viral infection of the brain leads to death or severe disability. The progressive multifocal leukoencephalopathy is confirmed by MRI and by examining the cerebrospinal fluid for the causative pathogen, and can also damage hepatic cells. So with this, we have to bring the patient frequently for your CMP, your comprehensive metabolic panel, to check the liver enzymes. Some other medications are here. You are free to read about them. But in general, I would say that you have to monitor facial flushing, GI disturbances with all these type of drugs. I will monitor facial flushing, GI disturbances. I will monitor skin reactions, allergic response, cardiotoxicity, and also I will double check your complete blood count because these drugs are affecting your immune system and probably your bone marrow production. So your complete blood count will be your RBCs, your WBCs, your platelets, right? You want to check on that. And then if you go farther, you are checking your white blood cells, your neutrophil, leukocytes, and monocytes. Okay, so I will monitor that. We don't need to monitor based on each presentation. No, in general, if you're having this type of patients, even the oncologic patients, you check for that. Medical marijuana is going to be used, and cannabis can reduce neuropathic pain, muscle stiffness, and spasticity for some patients with MS. Stem cells therapy is being researched as a promising treatment to manage MS, and not only MS, but also even patients that are blind are using the stem cell therapy. Athletes that are having problems with the joints, rheumatoid arthritis patients are trying to use the stem cell therapy, and good prognosis is coming from this. Improving mobility. Interventions. The symptoms of MS that affect mobility include spasticity, tremor, pain, and fatigue. Referral to rehabilitative services such as physical and occupational therapy can help manage functional deficits from MS symptoms. Severe muscle spasticity may also be treated with intrathecal baclofen, administered by a surgical implanted pump. Paresthesis may be treated with carbamazepine, which is our anticonvulsant. I'm just refreshing because I am sure you know your drug classification, right? or tricyclic antidepressants, propranolol, which is your beta blocker, and you need to monitor. If there are medications causing cardiotoxicity, you're gonna monitor your blood pressure, right? Below to systolic below to 100 and diastolic below to 60, your pulses below to 60 in case of the beta blocker. And clonazepam have been used to treat cerebral ataxia, right? Your clonazepam is your anti-anxiety agent, benzodiazepine, anticonvulsant, right? So administer this very careful. Usually call another nurse to help you and to double check the dosage and everything, okay? Protect your patient, protect your license. In collaboration with physical and occupational therapists, plan an exercise program that include range of motion exercises and stretching and strengthening exercises to manage spasticity and tremor. If needed, as last resort, neurosurgery, the deep brain stimulation, the video we saw related to Parkinson, may provide some relief from tremors. Increased body temperature may lead to increased fatigue, diminished motor ability, and decreased visual acuity resulting from changes in the conduction abilities of the injured axons. Okay, so that's good to know. We want this MS patient to do not get to the do not have the body in high temperatures, right? Because this is going to increase fatigue and is going to is going to diminish the motor ability and decrease visual acuity resulting from changes in the conduction abilities of the injured axons. I will have to say that these patients get very frustrated with the vision disturbances, because vision can help you relax. If you go to the beach, you can relax by seeing by observing the sea. You can see nature, you can read, that can give you some distraction. You can play an instrument, piano, a guitar, watch the TV, go to the movie, right? But when you're having this condition, everything seems to be more difficult in terms of coping, right? If the patient experiences dysarthria as a result of muscle weakness, refer the patient to the speech language pathology. Imagine visual disturbance, dysarthria, problem with the mobility. Is really it's very sad to see these patients and to manage them, because the medications that are helping them in one sense are really destroying the immune system and the bone marrow in other sense, and causing a lot of side effects, right? It is not unusual for the patient with dysarthria also to have dysphagia on top of everything. Managing decreased visual acuity and cognition. Alterations in visual acuity and cognition can occur at any time during the course of the disease process. Areas affected include attention, memory, problem solving, auditory, reasoning, handling distractions, and visual perception. So impaired cognition, assess with orientation by using a single date calendar. Give or encourage the patient to use written lists or recorded messages. It's gonna get to the point that recording messages or listening to different materials is gonna be the main point of distraction. To maintain an organized environment, encourage the patient to keep frequently used items in familiar places. Applications for handheld devices such as mobile phone and electronic tablets can also be used for reorientation reminders and behavioral cues. An eye patch, wow, that is alternated from eye to eye every few hours, usually relieves diplopia, which is double vision. For peripheral visual deficits, teach a scanning technique by having the patient move the head from side to side. Changes in visual acuity may be helped by corrected lenses. I don't know for how long, but if the disease is progressing, probably at some point it's not going to be that helpful. Complementary and integrative health, reflexology, massage, yoga, relaxation and meditation, acupuncture, aromatherapy, care coordination and transition management to help the patient maintain maximum strength, function and independence. Continuity of care by an interprofessional team in the rehabilitation and or home setting may be needed. In severe disease, placement in an assisted living or long-term care facility may be the best alternative. I don't know. I really don't know. Nothing is better than family. And if you're having problems with the vision, probably problems with the dysphagia, motor problems, cognitions, depression, I really don't know. Well, each case is different, and if you don't have enough support at home or your family members are seniors, is kind of this is probably the best option. The population of young and middle-aged residents in these settings is increasing as people with physical disabilities live longer. So we're going to evaluate the outcomes. To remains free of infection, maintains optimal mobility, maintains adequate visual acuity and cognition to function independently. With this, we have concluded the review of multiple sclerosis and also the analysis, very brief analysis of ALS, amyotrophic lateral sclerosis, ALS. When we come back, we are going to talk about the spinal cord injuries. So stay tuned. Thank you.